Getting? So if growth hormone, IGF-1 both high, we went to oral glucose. If it is still high, we went to a pituitary MRI. Okay? If we find some adenoma there, we labeled, okay, this is the cause of more of this problem. If there is no adenoma, then ectopic problem, some other problem is there. Okay? And to find that ectopic problem, we did CT of chest and abdomen. This is a flow chart how to approach, how to diagnose the case of acromegaly. Okay? Growth hormone excess. Any problem, any confusion, any question, please.
So for the hyperfunction, there is only one test is definitive, confirmative.
Mainly this is a test. This glucose is the main test, as insulin was there. So for that we usually use glucose and then the MRI and other things. Okay?
The main test is oral glucose?
Yes.
Doctor, what's the significance of CT chest?
Because ectopic, it will find some other tumor, maybe some other tumor which is secreting growth hormone. Not the pituitary or hypothalamus. A problem is there. Some other tumor is there which is secreting growth hormone. So growth hormone is there, but we want to find the cause. What is the cause of that? So we do that. Any other tumor is there which is secreting, which is called ectopic. Ectopic means outside from others. Okay, now proceeding further, hyperprolactinemia. Okay, prolactin, now prolactin is more, we are talking about that. So it is done in all women with amenorrhea and males with hypogonadism and all patients with pituitary mass. So this is the first thing in which patient we will do that. So with these symptoms, amenorrhea, when menses are stopped, or males with hypogonadism, or patient with pituitary mass, something is there in the pituitary. So we do this. And again, at least 2 other occasions. It should be done not once, it should be done 2. Prolactin level. We are talking about prolactin level. And concentration more than 200 nanogram per ml usually indicate a macroprolactinoma. So it is significant value, means more than 200 is significant. That means the pituitary problem, that pituitary is secreting more prolactin. Okay, simple. One thing to rule out is pseudoprolactinomas. Pseudoprolactinomas. So what is that? That mild elevation sometimes occur of prolactin, not more than 200, 50 to 200. When other anterior pituitary tumors compress the hypothalamic pituitary portal system. Some other tumor is compressing the system, due to which inhibitory hormone is not delivered. So what will happen if inhibitory hormone is not delivered? Prolactin will increase. Because inhibitory hormone is not coming, inhibition is not there, so prolactin will increase. So it is not the problem of the pituitary. It is a problem that some other tumor is compressing the pathway, due to which inhibitory hormone cannot reach the pituitary. This is called pseudo. What is pseudo? False prolactinomas. They are false. Actually, it's not a prolactinoma, not the pituitary problem. It is the false that prolactin level is high. It's not true. Okay, pseudo. So what we do a treatment with a dopamine and agonist, which should lower prolactin concentration in cases of true prolactinoma, but will not reduce prolactin concentration in pseudo. So in a true actual pituitary problem, it should decrease the level of prolactin. But in pseudo cases, it will not decrease. So this is how we differentiate pseudo and a true prolactinoma. Okay? So in hyperprolactinemia, we are talking about hyperprolactinemia. Okay? Forget about the previous things. The important point in today's lecture, when we are focusing on something, focus on that. Okay? So we are talking about hyperprolactinemia. So hyperprolactinemia, we have talked that we have to differentiate with pseudoprolactinomas. So how we differentiate? By this dopamine agonist. If true, then it will decrease after dopamine. If pseudo, it will not decrease. So prolactin level is the main thing in these conditions. And few things should be ruled out. Ruled out means you should look that patient should not be pregnant. If you are labeling the person hyperprolactinoma, so these things should not be there. Patient should not be pregnant and should not taking the other drugs which actually raises the level of prolactin, or primary hypothyroidism should not be there, and MRI and CT of for the pituitary region to exclude the tumor. So these things should be done before labeling the person. So this is a flow chart. Hyperprolactinemia means more prolactin level, okay? Okay, more prolactin level. Hyperprolactinemia, more prolactin in the blood. So first of all, exclude pregnancy. The lady should not be pregnant. Okay? Then look at the prolactin level. It's more than 200, prolactinoma, simple. Okay? Do the MRI of pituitary gland. Prolactin level less than 200, rule out other physiological causes, exclude hypothyroidism, etc. No need to memorize these. But the important points is that you should rule out these things. Okay? No need to memorize all these the signs and symptoms, etc. Rule out that patient on drugs or not. Okay, if he is on drugs, not able to discontinue drug, the drug is necessary. So do the MRI. Or discontinue the drug, and if still hyperprolactinemia persists, go for MRI. If it may be drug induced, so after discontinuation, it may resolve. So important point, the key point, if we are labeling a person he has more prolactin level, abnormal due to pituitary, the important point is that rule out pseudo. Rule out pseudo. Other thing, rule out pregnancy, rule out drugs, okay? Rule out hypothyroidism. So after ruling out many things, then you can label a person that he has some pituitary problem. And MRI is also important, or CT scan. This is the key message or summary of this hyperprolactinoma. Got it? Simple. Rule out pseudo, rule out pregnancy, rule out drugs, rule out hypothyroidism. If everything ruled out, go for MRI. Okay? If prolactin level is too high, then you can even go straight to MRI. There are other things usually with hyperprolactin level that usually LH and FSH are low in these patients. So these are helping point, you can say helping points that for the diagnosis. They usually have low estradiol, and these usually have low testosterone due to and oligospermia. What is oligospermia? Very good. Decreased sperm count. This is not just that, these are additional points. Okay, so anterior pituitary is finished. Anterior pituitary. Okay, and we talked about anterior pituitary, growth hormone, and prolactin. First we talked about hypo, and then we talked about hyper, or regarding growth hormone and regarding prolactin. Now we are stepping to posterior pituitary. Again, in this posterior pituitary, we will focus only on ADH, not on oxytocin. Okay, because it will be covered in another module. Okay, disorders of ADH activity. Now focus on that. Just for the time being, forget the past lecture. Now just think we are starting a new lecture. Disorders of ADH activity. Okay. So hypofunction. First of all, hypofunction. Diabetes insipidus. Okay. So deficient production of or action of ADH results in polyuria. So more urine. Now, it's very easy, not too difficult if you keep this concept. ADH, what is ADH? Anti-diuretic. What is the main function of anti-diuretic? Water resorption. If it is not there, more urine. Okay, simple. Now, I will ask you, you will answer. The rest is very easy. If more urine, what will happen to the osmolality of the urine? Okay, good. What will happen to sodium in the urine? Huh? Sodium I'm talking. Sodium decrease. Hypo, na? More urine.
The urine.
More urine. I'm talking about urine. Sorry?
There is low and sodium is decreased.
Okay, so, but the quantity is more also, na? Urine. The quantity, water is also more. This is the idea. What will happen in the body? First of all, osmolality. What will happen in the? Increase. Because more water is losing. So, less water in the body. So, this is a key concept. This is an investigation actually. So, urine, osmolality, what will happen? Decrease. More urine, more water. More water, what will happen to osmolality? Yes, simple. So, more water in the urine, less water in the body. So, less water, more osmolality. The same investigation. Okay. So, polyuria, low urine osmolality. So, simple, more water. High serum sodium, high serum osmolality. Getting? High serum osmolality, why? Because water is losing. Low urine osmolality, because water, there's more water is there. High serum sodium, because more osmolality. So more sodium, osmolality. Okay, this is the key concept. Don't worry about the values. Got it? More water, less osmolality. This is the key idea. More water in urine, less osmolality. Less water in the body, high osmolality. Simple. Okay, if the diabetes insipidus you are not clear, there's other test called water deprivation test. This should be performed. So what will happen if this water deprivation, normal person, if we will not give him water, what will happen to ADH? ADH will increase to conserve the water. Okay, if we are not giving water, so ADH should increase. But what will happen if urine osmolality? Okay, now what will happen to urine osmolality after water deprivation? Because urine is less, so urine osmolality will increase. Are you getting? When water in the urine is less, osmolality increase. Why is opposite? Volume of the water decrease, osmolality increase. Okay. So urine osmolality increases. Okay. So it means this is normal. Person has normal phenomena. Okay. Are you getting? Urine osmolality doesn't change by much. So diabetes insipidus. So person is not responding to this stimulus, and ADH is not releasing. So diabetes insipidus. So then what we do? Increase in urine osmolality upon desmopressin administration. Okay, now please focus. Now first of all we want to check that this urine, more urine, what is the reason of more urine? Okay, we do a water deprivation. We decrease the oral intake of the water. Okay, we deprive the patient. Then we look at that. If the urine osmolality increases, this means ADH is there. If urine osmolality is not improving or changing, this diabetes insipidus. Now there can be two things. ADH is not released or kidney didn't respond. We call it central diabetes insipidus and nephrogenic. Okay, nephrogenic means kidney. Either there is central problem or kidney problem. So we have to differentiate these two. Problem is there. Body is not responding to ADH. Now ADH is not there or kidney is not responding. So to differentiate that, we give desmopressin to the person. So increase in urine osmolality means the person respond. It means there's center problem. Desmopressin. This is also agent which should raise the ADH level. Okay? Or no change in urine osmolality upon desmopressin administration, nephrogenic. Okay? So this is nephrogenic problem. So this is a differentiating test. There is one other thing also for the same thing, that we can give ADH. We can give the ADH. Just focus now on this slide. Okay, focus only on this. What is this slide? Standard water deprivation test. Okay, the same. We are doing water deprivation. Deprivation, do you have any idea deprivation? That we deprive the person. We stop water. So state means normal person. What will happen in normal? Normal ADH level. After water deprivation, the urine osmolality increases, normal. After water deprivation and ADH increases further. We water deprivation and then we give ADH also. So in a normal person, all urine osmolality should increase. In other words, urine will decrease, volume will decrease, osmolality will increase in a normal person, and after ADH it will increase further. Got it? Normal. If you are not with me, tell me. What we are doing? We want to check the ADH. Okay, what does ADH do? It stops the urine. Okay, decrease the volume of the urine. When it decreases the volume, it increases the osmolality of the urine. This is the key idea. In a normal person, obviously ADH is normal. After water deprivation, ADH should increase normally, and it should increase the osmolality of the urine. And furtherly, we can give ADH, so it will further increase the osmolality because body is responding. Are you getting? Now come to next. Central diabetes insipidus. Forget the next thing. Focus on one thing. What will happen? What is plasma ADH level? Low. It's not producing. It's not producing. Okay, ADH is not there. After water deprivation, what will happen? Means ADH is not there, so what will happen? Nothing will happen. Okay. After water deprivation and ADH administration markedly increase, because ADH was not there, so now we are giving the ADH, the response will come. Getting point?
After prevention test in central why does the urine increases urine?
Why this occurs?
Yes.
After water deprivation, what should happen in a normal person? ADH should come, na? In a normal person, if water is less, ADH should level increase. But here the center problem, ADH is not there. ADH is not excreting.
But when you get less water, then this water will be excreted in urine. So then it increases osmolality.
You are saying if you are giving less water,
This water will be excreted in urine.
you are right, relatively it will be less, but in comparison, you are right, means relatively it will be less, but you compare with a normal person, na? The response of a normal and response of the patient. You always compare, otherwise there is no standard. How can you judge this is less? What is the less? You compare with the standard. Then a normal person response in comparison to that, this is low. Okay? Okay. Got it now? So after an ADH you give, so ADH will now come to play. Okay? Nephrogenic. Now focus only on that. What is ADH level? ADH is there. Okay, kidney is not responding, ADH is there. After water deprivation, before ADH, what should be there? ADH is there, but it's not working. Kidney is not responding. Okay? And after water ADH administration, no change. Well, ADH was already there. You can increase the ADH level, but you cannot do anything. No response is there. Okay? Clear? Polydipsia, a person is taking more water. So here, ADH normal or low, markedly increase urinary osmolality after water deprivation and increases further. So this is not our discussion, just to differentiate. Important are these two things. You should be very clear about these. Are you clear? Any question, any confusion, any comment, please? ADH decreases the urine volume and increases the urine osmolality. Okay, water is less in the urine, more osmolality. In a normal person, ADH is normal. Just focus on that, forget these things. ADH is normal. After water deprivation, ADH level increases in a normal person. So osmolality will increase because ADH will play its role and absorb the water. So osmolality of urine will be more, normal person. And after water deprivation and ADH administration, it will increase more. Now central, focus on that, forget about rest. In central, ADH level is less. Problem is what? ADH is not there. After water deprivation, what will happen? If there is no ADH is there, no secretion, so no, it will be low dilute urine, same in comparison to that. And after water and ADH administration, now then it will increase because now you are giving the ADH. Problem was that ADH was not there. Now you are giving ADH. The body will respond normally. There was no problem with the kidney. Clear? Now focus on this. ADH nephrogenic, problem in the kidney. ADH is there. No problem with the ADH. After water deprivation, so ADH is there, so but kidney is not responding. ADH may be too high, but if kidney is not responding, what will ADH do? And again, if you will give more ADH, same result, kidney is not responding. Okay? Now the hyperfunction. We have discussed the hypo, now hyper. Okay? This is called syndrome of inappropriate antidiuretic hormone secretion, SIADH. So now what will happen? What about the urine volume? More retention. What is the osmolality? Good. So same thing. Plasma hypoosmolality because more water retention. Hypo. Persistent dilutional hyponatremia with more water, so dilutional hyponatremia means sodium level will be diluted. Elevation of urine osmolality. So less urine, more osmolality. Decreased urine output, inappropriate high urine sodium. So less volume, more sodium will be there. And plasma ADH, plasma renin concentration. This is characterized by high ADH concentration and low renin concentration. So this is an important thing that first readings you should be clear. The plasma hypoosmolality, urine hyperosmolality. Okay? Urine, decreased urine output. This is clear? Okay, now we will proceed. Okay, this is so what is this high ADH concentration and low renin concentration? Obviously ADH is more and renin is less. These things are important. So if this is the end of the first lecture, we have talked about the pituitary in this lecture. So we discussed anterior, growth hormone and prolactin, then the posterior, ADH, hypo and then hyper. Okay, hyper is simple, that these values should be clear. That what will happen to plasma, what will happen to urine. Clear? Should I proceed to next lecture?
Can you repeat the point number 6?
It's not so important. That plasma ADH and plasma renin concentration, what will happen? The ADH is more, so it will absorb, so renin will decrease. You will find in next lecture, you will find the significance. In next lecture it's important. This point is given, then correlate with the next lecture. Then you will find the answer. Should I proceed to the next lecture? It's up to you, but 5 minutes.